Thank you for the invitation. I would, first of all, like to show a disclaimer. Dolutegravir is the best second-class drug we have, no doubt about it. Brazil is the country that mostly prescribes dolutegravir in the world, and if something new and different happens, we will definitely see it here first. And we are going to discuss it in the settings of resistance as well. There's something else, which is a paradigm shift, and that is the development of antiretroviral uh, drugs. I mean, we understood the replication cycle of HIV, and we designed the molecules to inhibit stages of the replication period. That was new. Today, we do the same thing for Hep B, for respiratory syncytial virus. We did it for Hep C, but not before. Beforehand, we would get medications in extracts, and it means that we are experiencing a much more modern phase, and we will no longer find antiretroviral drugs in the backyard. And in these settings, we had the development of the first integrase inhibitor, raltegravir. I've got to tell the history of raltegravir because it impacts on dolutegravir resistance. It was developed by Daria Hazuda. That was a great thing, but that was another HIV replication cycle being inhibited. And it's important because that enzyme gets the CDMA that was done to the cytoplasm and it brings it back to chromatin. I mean, brings it in chromatin. And then there are lessons learned from raltegravir. First of all, on the genetic barrier. A genetic barrier that's not low, perhaps very close to no booster PI. When you look at the naive patients, there will be about 25% of resistance. But raltegravir all over the world, it came in through the back door. It came in for salvage of multi-resistant patients. And then we learned, of course, that you will have more resistance to the integrase inhibitor. This one, 60-80% benchmark. In Brazil, we found 26% of such patients on raltegravir during times when the criteria to prescribe raltegravir was resistance against protease inhibitors, so a moderate to good genetic barriers. And we also learned from raltegravir that it includes distinct resistance pathways, the way that the path is pushed towards resistance. These are it. 124, 143, and 148, which leads to cross resistance to dolutegravir. We saw it, for instance, in vitro in a phenotyping assay. These are the mutations, the three pathways, 155 to the 143, 148, all of them with a high resistance level to raltegravir. That was a change here. But the only one actually having greater than 1 to dolutegravir is the one that includes the 148 pathway. When we look at what happened in Brazil, these are patients failing to raltegravir since 2017 to 2018 are included all three pathways. The 148, that's the bad news, cross resistance. It happens more frequently than the other two. We also learned, and this is not yet published, that the HIV subtype might be associated with those pathways. You see, in orange, we have all three pathways, and the 148 pathway, the evil one in Brazil, we have more the subtype B than the other subtypes. C and F percentages right here. This is new. And what we also learned was that you change the pathway. You start with the 155. Here it is. These are the same patients throughout the time, and then the 155 pathway is replaced by 148. That's the bad news, the cross resistance. In Brazil, we saw the same thing. These are not the same patients, though. These are patients failing the raltegravir 1, 2, 4 more years. And the greater is the raltegravir use, the greater is the prevalence of 1Q48 pathway. And after raltegravir, we developed other integrase inhibitors to improve. Those drugs that bind to the structure of the enzyme, they have power to improve, such as protease inhibitors. We managed that the amount of protease inhibitors would inhibit the enzyme with the use of raltegravir. In analogues, we found a more flexible analog than travirin to bind for longer near the active cycle of reverse transcriptase. And then we changed the molecule of integrase inhibitors. We left them more linear second generation dolutegravir, bictegravir, cabotegravir, so that they will be binding for longer to the integrase. That's what we call dissociation time. Whenever you have a greater dissociation time, it means that it is bound for longer. It will inhibit the enzyme for longer, because that's not a definitive inhibition. This is first generation raltegravir. It is easily raltegravir, evategravir, and then if you look at the second generation of raltegravir and bictegravir, they dwell for longer, bind to the enzyme. This is good because it impacts on the genetic barrier. It will be higher. This you can measure in vitro. So you cultivate the virus with a small amount of the inhibitor. You do the passages. Each spot is a passage. It means that you give more cell to feed the culture. And you see, before we have the mutation resistance to the first generation compared to the dolutegravir and bictegravir. Higher genetic barrier, and it means, for instance, that you need a greater number of mutations in order to have a more comprehensive resistance to second generation inhibitors. This is bictegravir and raltegravir. Little resistance will already grant a lot of resistance. For dolutegravir and bictegravir, to give more resistance, you needed to associate mutations. We still have this residual activity, and we have the clinical evidences that the genetic barrier to regimens with the two analogues and one second generation integrase inhibitor, dolutegravir or bictegravir, is very high because there is no resistance at all. In clinical resistance, if it fails, dolutegravir is not to blame because there is no resistance to anything whatsoever. However, we also learned that you can actually have dolutegravir resistance in initial treatment, and for it to happen, you must have monotherapy. Resistance to dolutegravir in initial treatment is monotherapy. That's what the mono showed. 95 patients, 8.4% of failure after 1 year, 3.2 resistance. Now, we have resistance to raltegravir. We start seeing resistance transmitted to integrase inhibitors in Brazil. I'll show you shortly. And we must think about the effects of that. And this is a study we performed recently. We just presented in Congress. It's not published yet. We got some capital cities such as Belém, Salvador, Brasilia, Rio de Janeiro, Santos, Porto Alegre. We got Santos, not a capital, but with a lot of resistance transmitted, and Itajaí, not a capital either, because of the high mortality rates. And we checked the resistance profile of resistance. If you look at the second column, the epidemic is quite concentrated in the city, apart from Porto Alegre, which is nearly half of women. Patients progress a lot. The CD4 count medium is quite low in patients with recent diagnosis. But here in this column, we have the prevalence of resistance transmitted. We consider low, below 5%, intermediary between 5 and 15, and high above 15. Here we have a prevalence that tends to be more intermediary, although it appeared as high in Rio de Janeiro, the 20%. And here we basically have the profile of patients according to the prevalence of transmitted resistance. For analog 6.1%, you see, the 2015, there is no classic mutation of 215, 215Y or F. You know, this is a marker of transmitted resistance. You see, in red, this is for the analogs, but in red, those mutations we considered important for transmitted resistance. I mean, it didn't appear driven by the virus polymorphism. But in blue, we also have a description of resistance to non-analogs. In red, I have 103, 5.7% of resistance to non-analogs, and a lot of resistance associated to 138. That's not listed as mutation of transmitted resistance, but it's important for real pivarin. For protease inhibitor, this is quite low, only 2%, about the nose is here. And the Integrase 1.6%. There is no precedence. Whoever reported transmitted resistance to Integrase inhibitor was the Mediterranean Consortium, Portugal, Spain, Greece, and Italy. And there it is 3 times low. I mean, we found 1.6% of mutations. Those in red are the ones that matters. But there are other mutations that are secondary mutations not related with transmitted resistance. There is transmitted resistance to integrase in Brazil, therefore, nearly as much as we have for other things. What it means, I don't know. I'm not sure initial treatment will failure because of that, but in a recent study, we found an association between transmitted resistance, even to other classes, and failure. This study, which we assessed, we got to the first patients failing to two analogs, tenofovir, amlodipine, and dolutegravir in Brazil that went for genotyping after 2017, when we started to have dolutegravir as first line of treatment. And here we got the first 113 patients. We tried not to overestimate resistance. You know how? We went to the database. If patients were in a city that didn't have cyclone before 2012, we just excluded because we're not sure the person was exposed to the drug or not. If the CCR included the decrease in an unexplained decrease in viral load, we excluded. Also, increase of CD4 without explanation, we excluded. So from 300, we selected 113. Of the 113, we realized that 7 had resistance to integrase inhibitors, those important resistance, those that are showing clinical trials to analogs and dolutegravir, no resistance whatsoever. Here we found a mutation on 118, very important for subtype virus, subtype C, 118, important resistance to raltegravir and dolutegravir. These 263 typical dolutegravir mutation in 4 patients, and 140 resistance to cabotegravir in a PrEP patient. So these are important mutations. Therefore, there are 7 mutations, 7 patients out of 113 patients. 7 patients. We also had an interesting thing, which was the association of a transmitted resistance with dolutegravir resistance failure, because the prevalence of transmitted prevalence in this group of patients was nearly 26%. You remember I showed you in Brazil, it was 11, 10. It was very much higher here. Mutations to protease inhibitors, to non-analog, to AZT. So we realized that there is an association between transmitted resistance and association with the mutation to resistance to dolutegravir. We can think of adherence, bad adherence, and transmitted resistance may lead to failure with resistance to dolutegravir. And here, just to show you about the transmitted resistance, to see how interesting. These are 34 patients who failed PrEP with a Truvada, tenofovir FTC. Two had good adherence because they measured the number, the amount of drugs in a filter paper when you look at tenofovir. These are the two red ones, but never mind. That's not what I wanted to show. I wanted to show you that there is a very high prevalence of transmitted prevalence in these PrEP failures. It means we have 10 patients out of the 34 with mutations, but 8 had no relationship with the tenofovir FTC. 138, 106, 46, which is protease, 138 for non-analog, 103 again, 103 again. A lot of transmitted resistance, and this is associated to a PrEP failure. So there is something about this virus that has transmitted resistance to other classes that may be associated with the treatment failure as well as treatment in prevention. Failure in prevention. Something else. Part of these patients in our study, 15 had under 500 viral load, and 7 had resistance mutation, which is the one bold letter. So even with a low viral load, you have mutation resistance, which are not the main resistance, but they are accessory resistance in the failure to dolutegravir. But now we hear a lot about patients who take patient in a proper way, adhering to the treatment, and then with viremia, low viremia sometimes, and then you genotype, there is no resistance mutation. Wouldn't it be really resistance? Wouldn't it? Maybe we just don't know exactly the genotypic correlates of resistance. I will show you a very interesting thing, getting back to PrEP once again. Well, people failure to cabotegravir as PrEP, little. Failed a little. Of the 16 who failed out of 2 and to nearly 2,300, 12 appeared during treatment. 4 of those were already infected at entry. Let's look at the 12. 5 of them appeared with resistance mutation to integrase inhibitor. 5 of 14, because in 2 they couldn't genotype. 1 already started with the resistance, was already infected with the virus at entry, but 4 developed the resistance. I will not show you the data, but in these 4 you have evidence of a transmitted resistance to non-analog and to protease inhibitor. I will get to my point shortly on this issue of transmitted resistance and the lack of resistance genotypic correlates. First of all, you know what we learned? We learned that we looked to integrase to find about integrase inhibitor resistance, but the mutation may be out. Integrase is right here. It is the last part of this, but we have a mutation in F, very far selected by an integrase inhibitor. This is 3-line PPT, but the vocation of integrase is to get the DNA and place in our chromatin. But this study showed that whenever you have a mutation on 3-line PPT, the virus will come without integrase. It doesn't need it. This is the resistance mechanism. And we saw it in Brazil. Out of 51 patients failing to dolutegravir, some had been exposed to raltegravir, and 6 of those had this mutation, and we don't look to it. These are there. Whatever is no, it means that they weren't exposed to raltegravir before. Only 1 had integrase mutation, and the other ones were 3-line PPT. But it's going to get worse. Allow me to show an in vitro study that was presented at the last GROI. They developed a protocol for in vitro resistance. They cultivate a virus, and every time you increase the number of virus or the viral load in culture, it means that there is a resistance. And they saw resistance mutations, but the mutations were in the envelope, not in integrase. You see, this is fold change. I mean, whenever you have the wild virus, this is one fold change. And whenever you have the resistance, you increase more than 3,000 times the resistance. It will appear in time as it did up there. And you know why? Because these mutations within the envelope increase the enzyme that multiplies HIV, reverse transcriptase. I mean, the mutation appears in the envelope. The virus multiplies so much that the drug cannot cope with it. It gives us cross resistance not only to integrase inhibitor, but also to analogues, non-analogues, and protease inhibitor. The mutation is in the envelope, but that we also have mutation in GAC, which leads to resistance to integrase inhibitor. The conclusions is that we still don't know well the actual mechanisms and resistance correlates to integrase inhibitors, and we must also consider that in failures where you do not have instruments to detect resistance, that may be lack of susceptibility to drugs, and it may change our clinical approach. Thank you very much for your attention.